Olá, eu sou Vera Lúcia Conceição de Gouveia Santos, professora titular do Departamento de Enfermagem Médico-Cirúrgica da Escola de Enfermagem da USP em São Paulo. O meu objetivo hoje é apresentar um webinar sobre dor isquêmica em doença arterial periférica. Nosso palestrante convidado é o professor Dr. Kevin Nu. Dr. Kevin Nu é professor associado da Queen's University School of Nursing e também da School of Rehabilitation Therapy. É também pesquisador e professor adjunto da Western University, junto ao Programa de Mestrado em Clinical Science in Wound Healing, no Canadá. Este webinar é promovido pelo Grupo de Pesquisa em Estomoterapia, o GPET, credenciado no CNPq e coordenado pelas professoras doutora Paula Nogueira e por mim, além do Programa de Pós-Graduação em Enfermagem na Saúde do Adulto, PROESA, ambos da EUSP. Esse webinar abordará como tópicos revisão sobre dor isquêmica, boas práticas no controle da dor em feridas e outros tratamentos como compressão pneumática intermitente, eletroestimulação transcutânea e terapia por ondas de choque. O webinar foi gravado originalmente em inglês e estará disponível também em castelhano e português por meio de legendas. Muito obrigada e aproveitem.
Oh, hello everyone. Welcome to the webinar. My name is Professor Kevin Wu from Queen's University. I'm also a visiting professor at the University of Sao Paulo here and spending 2 weeks at the school to deliver a course on research and methodologies. Today I'm going to talk to you about a topic around lower extremity arterial disease and how we can manage ischemic pain. There's 3 different objectives I want to deliver today. First of all, I want to review ischemic pain and the scope of problems associated with peripheral vascular disease. And I want to praise the best practices on the management of ischemic pain, looking at all the available literature for us. And then I think at the end I want to examine some of the emerging strategies and techniques available to us for the management of ischemic pain. As you're aware, there are different types of leg ulcers. It could range from diseases that involve inflammation, it could be related to malignancy, drug-induced, or even in some individuals with obesity, they're more likely to develop certain type of leg problem. We call that lipedema. And when you look at the different types of lower extremity ulcers and diseases, the most common problem that we come across are venous insufficiency related ulcers or venous leg ulcers that constitute about 40 to 85% of those individuals present to us with ulcers. And then about a range of 5 to 30% with pure arterial disease. And I think probably this is a growing concern with arterial problem because of the obesity, the prevalence of diabetes problem. And as you know, diabetes is related to advanced atherosclerosis. So I'm sure that in the future we're going to see a growing concern around arterial problem. And not to mention about the mixed disease involving the arteriovenous disease. So I think, and that's why we continue to do different demographic studies to evaluate the trend in terms of the development. Part of the reason why we want to classify different types of leg ulcer, and especially with arterial disease due to poor perfusion to the skin and ulcers, is to determine the potential for healing. The term we use is healability. Healable wounds are ones that we can correct all the etiologies and that there's enough perfusion to support wound healing, versus most of the arterial ulcers without the interventions, meaning without any surgical interventions to improve blood flow, they would consider to be non-healable ulcers. I can speak about the phenomenon and the problem in Canada that may be slightly different in Latin America. The peripheral artery disease affects about 4% of all Canadians over the age of 40 and up to 20% individuals who are over 75 years of age. So you can see the correlation between the disease, the prevalence of the disease, and age itself. And when you look at the international guidelines, in fact, there are many different guidelines available to us, published, indicating the best way to manage arterial disease or peripheral vascular disease. But there's no real direct recommendation that takes into account the quality of life, age-associated changes, and physical frailty among individuals. And what we're actually quite disappointed is the lack of direct and concrete suggestions and instructions how we should be managing ischemic pain as well. And that's the impetus for us to look at and collectively looking at the available literature. What are the potential interventions that we can use to manage pain better in this population, especially individuals who fail and they may not be surgical candidate because of the severity of the disease, the location of the blockade, occlusion, and a lot of times people are not candidate for surgery because of the number of chronic diseases they have, and also, of course, patient preferences. One of the ways to do with ischemic pain is to receive an amputation, and in fact, in my country, most people do not like to have an amputation due to a number of reasons. So pain is a major concern that has been some of my work in the past, really delving into the different variables affecting the pain experience. There's no doubt pain is the major reason why people suffer from chronic wounds. And what we're trying to do with this project is to evaluate and develop some best practices around ischemic pain management. This is a project funded by the Canadian Institute of Health Research, the Planning and Dissemination Grant. The overall purpose of this project is to generate best practices, recommendations, and quality indicators for the management of ischemic pain, as I said, especially in the older, more frail individuals with low extremity arterial disease, or LEAD, across a continuum of healthcare settings. In fact, this project can be divided into 4 discrete phases. First of all, we look at the available literature for us. Understanding there's a lot of practice guidelines out there already, we decided that there's no point, or there's a lot of work to go through all the primary studies. And a lot of the guidelines, they have panels, expert panels, that gone through a very rigorous process to retrieve the best evidence to support their individual recommendation statements. So we decided to do something called review of reviews. The other term we use in the Johannesburg Institute methodology is umbrella review. And we focus primarily on the management of pain, claudication, and leg pain in people with low extremity arterial disease. Following that, we actually assembled a group of experts, including palliative care, vascular surgeon, nurses specialized in wound ostomy incontinence or ET nurses, and also we included people from nursing associations that has published a lot of best practice guidelines in the nursing area. So we have this big group of people, and of course we have practice individuals that are very, very close to delivering care to patients with LEAD and ischemic pain. So we met for 2 days and come up with some of the best practices, appraise the literature, and part of the purpose is also to look at the clinical experiences, understanding that some of the strategy may not be available in the literature, so we want to capitalize on individuals' experiences to come up with some of those credible recommendations. And then the third phase that's still in process is based on some of those recommendations. We want to construct a survey that we can send to a broader audience for review, and also to get feedback to determine whether those recommendations are sound and reasonable for them to implement in practice. And then the last phase is we're looking at strategies that we can disseminate the best practice recommendations across Canada and perhaps even internationally to look at different ways to make sure that we provide better care for this cohort of people. So first of all, I want to talk about how we go around doing our literature search. The first step is to identify all the relevant information. So we work with a librarian scientist at Queen's University. Her name is Amanda. We decided to look at only English language publications from 1946 to 2019. For umbrella review, we only look at review papers, literature review, systematic review, meta-analyses, meta-synthesis, or guidelines that are published. One of the limitations, I think, is we did not go through individual professional associations to determine if they have any guidelines that they have already, unless they're published in the searchable database. So we use a number of terms. It could be ischemic pain, including PAD, peripheral artery disease, and claudication. And sometimes it's about pain with walking in people with PAD. So we use a diversity of pain of the indicators to search for the appropriate literature. The outcomes, including pain management, pain relief, pain-free walking distance, are often reported in the literature, and also the maximum walking distance. So using those terms and strategy, inclusion, exclusion criteria, we come up with 281 references. We excluded 15 of them because they were duplicates. And we have about 4 to 5 graduate and undergraduate students working with us, at least 2 individuals at a time, to review and screen all the title and abstracts. At the end, we excluded another 86 of the papers because they were not relevant and didn't really quite fit the inclusion criteria. And some of the papers were just editorial and opinion papers, and they were not really good review papers. So, and I think this is, and then of course we go through each individual paper with at least 2 reviewers and assessors to extract all the information in tabulate in a table in order to do better summary. So this is a Prisma diagram to indicate the step-by-step how we over time eliminate some of the irrelevant information and papers. At the end, we come up with the 93 studies in this umbrella review. So let's get to some of the key recommendations here. The first thing we want to make sure people are doing when they come across any individuals with ischemic problem or even with the peripheral artery disease is to make sure that we conduct a comprehensive review, including the medical problems, social history, and the lifestyle history, and of course the symptomology. So for anyone over 50, there should always be a question to make sure that they don't have any symptoms in relation to PAD. And that's consistent with number of guidelines because you may think 50 years is pretty early, but a lot of times atherosclerosis and PAD can occur as early at that age. And we recommend the importance of family history, smoking, any history of high lipid, hypertension, and also diabetes. And of course, diabetes is a very important indicator for peripheral vascular disease. Understanding that the diabetic foot ulcer occurrence, the key risk factors are 2 major ones, including the loss of protective sensation due to neuropathy or because of vascular problem. And from our study that we have identified in a database that we use through the Institute of Clinical Evaluation Science, that with the 200,000 individuals in that database, that the mortality within 1 year post-amputation could be as high as around 30 to 35%. In 5-year time, the mortality raised to about 60%. So that's a very deadly, very high mortality related disease condition. The other recommendation is, other than taking a good history, is the importance to clinically do a proper evaluation and assessment. And of course, in the literature, it's not extremely clear what's the best way to approach. We include a number of parameters using the Berger's test to evaluate any dependent ruber problem that usually indicative of a circulation issue. And dependent ruber is when the leg is assuming this sort of dependent position. The improved blood flow will stimulate a hyperemic response, resulting in the reddening of the leg. So you can see in this picture here, one leg is redder than the other, more erythemic, upon assuming this dependent position, and that's a really good indication of a peripheral vascular disease, especially in the left lower leg. We also highlight the importance of using the capillary review testing, evaluating temperature difference to see if there is any area that is cooler, suggesting potentially a decrease in circulation. We continue to advocate the use of pulse to indicate the adequacy of perfusion. So just because the pulses are palpable do not always suggest that there is a good circulation. As you can see, the test itself has a sensitivity of 67% and a specificity of 86%. In other words, if you can feel a strong pulse, you cannot always guarantee there is a good circulation due to the calcification of blood vessels. So you can always have a false elevation due to non-compressible blood vessels. As opposed to the fact that if you cannot feel the pulse, then usually I think we're pretty confident that there is element of circulation insufficiency. So again, this is a good summary slide in terms of the type of statistics available in the literature, that the sensitivity is a lot better than the specificity. So, but again, there's still a value to conduct this test on a regular basis. And of course, part of the evaluation is to ask the patients about the symptoms in relation to claudication or ischemic pain. And in the literature, they describe that the pain may start with pain upon exercise or related to exercise because of the demand from the exercising muscle outstrip the supply of oxygen to the exercising muscle, resulting in collection of lactic acid and toxic waste, and that's why patients experience ischemic pain. So as the disease becomes more severe as it progresses, then patients may experience night pain or even rest pain. And in fact, there's some literature suggesting that we should actually looking at the location where the patient experiences claudication or ischemic pain, and that may have a correlation to where the occlusion is. As you can see in these two slides, there are different areas that are involved. So I think the pain also could be related to the ankle brachial pressure index, which is a screening test to evaluate the severity of ischemic problem. So I think it's important to remember that ABI is being done from time to time, and based on the value of the ankle brachial pressure index and the ratio, then we often provide some first-line guidance whether the patient should be receiving further testing or evaluation, or refer them to the vascular surgeon for really critical assessment, because now the ischemia is becoming more problematic. So we call that critical ischemic limb. And for people not familiar with ankle brachial pressure index, it is a very useful tool recommended by all vascular societies and guidelines. Basically, you obtain the blood pressure in the arm around the brachial area compared to the blood pressure in the ankle. So usually what we expect to see is about 1. So the blood flow, the systolic pressure should be the same. There's a high limit, it's about 1.3. Beyond 1.3, again, suggesting there may be a atherosclerotic or calcification of the blood vessels, or false elevation. So if the ABI is below 0.9, there's usually an indication there is arterial compromise. But we often say that if the circulation is 0.5 to 0.9, there should be enough blood flow to support healing. So this is a nice little diagram to show you how we obtain the ankle-brachial pressure index. And now I think there is increasing attention to not just focusing on the value itself, but also focusing on the waveform. So if you listen to this, so you can actually distinctively listen to the 3 distinct waveforms with 3 components for each pulse, for each signal. So we call that sort of triphasic waveform, and indicating there's enough blood flow, versus if you only hear 2 components in the signal, it's a biphasic waveform, and suggesting that maybe a slight reduction in blood flow, and then monophasic is definitely indicating the arterial insufficiency. To circumvent or to increase the diagnostic accuracy, we often obtain the total pressure as well, the total brachial index. And of course, now we're applying the blood pressure cuff around the toe to obtain this pressure. And this is a summary table to indicate the reference values for the ankle-brachial pressure index versus the toe pressure index. And usually we prefer to see value for toe pressure from 0.4 to 0.7 to suggest enough blood flow for healing. And of course, arterial perfusion and other type of skin perfusion scanning is available for us. This is something that is available to North America using a handheld device, and basically what you see here in red discoloration under the near-infrared scanner, indicating there's a lot of oxygen-rich blood that is perfusing the area. So indicating, well, there's enough oxygen, enough blood flow to support wound healing. And this is a very interesting case that I used from my colleague in British Columbia, Rosemary Hill, and comparing the picture using the infrared, the near-infrared scanning machine, comparing before and after compression. What you see here before compression, because there's massive edema, all those edema fluid in the interstitial space is compressing or sitting on the vascular bed, compromising blood flow. And you can see that under the scanner is a lot of blue discoloration, indicating there's lack of oxygen basically. After compression, now you can see that this increase in perfusion, increased oxygen delivery. Now you can see more red color, which is good. So again, this is a good point about why we need to focus on bring attention to the fact that compression may be valuable, may be useful for the management of people with even with arterial disease, if they have edema problem. So other more invasive testing may include magnetic resonance angiogram, the MRA, or CTA, using CT technology to visualize the structural aspect of the blood vessels. And of course, the gold standard is looking at the angiogram, putting dye into the patient to evaluate the blood flow. And again, obviously, it's not appropriate for every individual. That's why it's a combination of maneuvers in a toolkit to arrive at the correct conclusion. The other thing I think we need to think about is, especially for people with arterial like ulcer, is the angiosome concept. The angiosome basically is a three-dimensional mapping describing the blocks of tissue being perfused by the different branches, the blood vessels that branch off from the key vascular supplies in the lower extremity. As you can see, there are actually 6 discrete geographical locations. So yes, you may have a good ankle-brachial pressure index because you're looking at the anterior tibial artery. But if you look at the heel area, if someone got an ulcer, you may not have enough blood flow, or you may have a blockade or occlusion in the calcaneal branch, and that's why those wounds may not heal. And more recently, the Vascular Society across the globe, whether it's European or in the United States, they promote the Wi-Fi risk assessment tool. Wi-Fi stands for wound ischemia and foot infection because those are the 3 parameters that we evaluate using this tool. In fact, there is an app that is downloadable and to facilitate the calculation of the score. So based on the scoring, then we can stratify at-risk individuals who may develop ischemic limb and they may actually end up with amputation. So we look at about 6 parameters, looking at the ulcers, the presence of gangrene, the ABI value, the systolic pressure, the transcutaneous oxygenation, and also infection. So the next set of guidelines, we also look at the importance of systemic disease control, especially with diabetes. The A1C should be under tight control if possible. But the question is, for old individual, what is optimal control? 7 is not recommended because it's maybe sometimes too low, and we don't want individuals who are frail and older to develop hypoglycemic episode that predispose them to falling. So we need to look at smoking cessation program and weight reduction, whether it's diet control or exercising. Talking about exercise, one of the key recommendations from a lot of the guidelines consists in surrounding the importance of regular exercise. And in fact, using delivering a standardized exercise program to individuals with ischemia has been shown to reduce claudication and also improve the walking distance. So there's 2 different types of programs available. One is supervised by clinicians, by professionals, versus some of the research evaluated home-based program. So they instructed the patients with ischemic problem to do exercise on a regular basis. And I think in the literature so far, the supervised program seems to work better. I think perhaps it is a way to improve patients' confidence and self-efficacy, the interaction with their healthcare providers, or sometimes they may have exercising group, may actually provide that psychosocial support milieu to facilitate the adherence. So as you're aware that calf muscle pump is the most important component to promote venous return, and now we understand that the calf muscle is not just working around promoting venous return, but also that may increase angiogenesis and new circulation. The other technology that's available to us in Canada is something called a gecko device, and basically what you can see in this diagram is a band with a battery disc, and what it does is stimulate the peroneal nerve, causing muscular contraction in the calf area. And you can see this is a couple of videos. Individual with spinal cord injury, and she was not able to move her leg, but with the muscular contraction machine device that she was able to move, and that may actually help stimulate new blood vessel growth. The other, based on the umbrella review, we find that there is very little good recommendations. So we actually move on to do some more focused research on some using the search term claudication and intervention studies, identify not just randomized controlled trials, but also other case control or cohort studies to inform practice to look at other potential recommendations. So one of the studies actually quite interesting is to recommend patients to receive or drink at least 2.5 liter of fluid per day, and that has been shown to be effective in reduce the experience of claudication. So by improving your hydration status, ensuring you're receiving a lot of fluid, increasing the circulating volume, bringing oxygen to the tissue may reduce the experience of claudication. And there's other new studies, ongoing study. One of the studies that I found was the use of dietary nitrate. They use something like a very highly concentrated beet juice. So apparently I think there's a lot of nitrate-rich substance in beets, and so individuals randomized in the treatment versus control. And this is a protocol published in the literature, so hopefully there will be some interesting finding in the near future. And I also want to point out that the compression may not always be contraindicated in patients with arterial disease. In this case, there's a case series published by Mosti and his colleagues from Italy. They subject individuals to varying degrees of various strength of compression therapy, as high as 31 to 40 mmHg of compression. As you can see in this graph, high compression did not compromise blood flow. In fact, improved the ejection fraction and also the transcutaneous oxygenation level. So the belief or the assertion that using compression is going to cut off circulation completely in all patients with arterial disease may not always be correct. So, and of course, depends on the type of skin, and often people, if they have mixed disease, they may have advanced lipodermatosclerosis, thickening of the skin and woody changes. Then a stiffer compression material may be required to provide proper compression. And another sort of interesting randomized control study that was published recently is to look at using unloading shoes to mitigate intermittent claudication. So I think that's actually a very important strategy that as nurses, as a non-pharmacological intervention that's very, very easy to use and to recommend to our patients. Basically a footwear that is not going to increase the stress on the lower leg muscle, and also it can reduce trauma. So I think that has two added benefits to appropriate footwear. Of course, there are long literature around the use of medication. We know that we need to address some of the key risk factors. So using lipid lowering agents. In the United States, they have cilostazol, a vasodilator, and there's some interesting papers or studies looking at antihypertensive medication. So some people think that, well, by lowering blood pressure, are you going to compromise blood flow? Well, no. In fact, you may actually improve circulation. And some of the studies that one of the medications that have been studied most is the ramipril, one of the medication in the ACE inhibitor class. Antiplatelet potentially can be helpful to reduce clotting, and aspirin has some anti-inflammatory property, and other anticoagulants are slightly less convincing, like clopidogrel and other antiplatelet medications, a fragment for that matter. Pentoxifylline is an inhibitor of platelet aggregation, some fibrinolytic property, and also it has the potential to reduce blood viscosity and improve microcirculation. That has been used quite extensively for the management of venous disease and potentially can be beneficial for individuals with arterial disease at the same time. Other type of medications, for example, prostacyclin for vasodilatation, and from our clinical experiences, we found that the topical nitrate may be helpful. But again, the science behind the use of topical nitrate is not very strong. It's difficult to see a randomized controlled trial at this point. What about analgesics? So yes, there are other medications, and morphine is definitely available and has been used, but not very promising and not always work for individuals with ischemic pain, especially individuals who are frail and older. High doses of morphine can be very, very dangerous. That can cause delirium, constipation, confusion, and all the other adverse problems. And we also understand that people with ischemic pain, ischemic problem, often involve nerve damage because there's not enough blood supply to maintain the nerve integrity. So some of the pain they describe in the studies could be in relation to neuropathic pain. So I think in the future, we're talking about the importance of doing further studies to evaluate how people describe ischemic pain. What are the key components when we assess for ischemic pain? So hopefully we'll be able to come back to talk about some more concrete tools that we are developing. There's also other medications, for example, acetaminophen and ketamine. Ketamine is quite useful, especially if there's nerve damage. Some herbal preparation, if you may, non-pharmacological approach, using ginkgo biloba, anti-inflammatory. And there's a couple of interesting studies looking at something called Padma 28. It is an herbal preparation from Tibet that's been tested for the management of ischemic pain with some promising results. So the exact mechanism remains unknown. We probably need to examine the product or the herb in a more careful manner to identify the active substance. And of course, with pain medication or pain management, we cannot escape the use of nerve block and also lumbar sympathectomy as a very, very effective intervention to block the entire pain pathway. It has not been very popular in clinical practice. It really depends on the culture of different settings, whether they have physicians or nurse practitioners in my country able to do the block. I think it's a very, very effective way to manage pain, and for, of course, it's not a long duration of time, and you might have to reapply the block from time to time. But I think for people at advanced stage of arterial disease who are not surgical candidate, we should really think about quality of life first. There's also some discussion around the use of oxygen therapy, especially with hyperbaric oxygen. That may be beneficial for people with arterial disease, depends how severe it is. If the circulation is very severe, even breathing in 100% of oxygen may not be able to deliver to the ischemic area and stimulate new blood vessels growth. There's also some newer interest around topical oxygen therapy, pressurized oxygen therapy. We know oxygen is important in many ways to kill bacteria, to stimulate new blood vessels growth, and also to promote wound healing. And the new technology now is the continuous diffusion of oxygen therapy. As you can see in this graph, HbO2 or hyperbaric oxygen therapy give you really significant high concentration of oxygen delivered within a short duration of time. Topical oxygen, low oxygen, also a short duration of time, versus a continuous diffusion therapy. Yes, it's slightly lower oxygen level, but a continuous, maintained at a very continuous, prolonged level. So other potential interventions may include intermittent pneumatic compression therapy. Electrical stimulation actually has received a lot has been tested in many studies as well. potentially could be quite useful. New studies even using the transcutaneous electrical nerve stimulation and the extracorporeal shockwave therapy potentially could be useful. So I think in the future, hopefully we have more physical, non-pharmacological modalities available to us, understanding that older, frail individuals may not always benefit from systemic medication. If we can prevent circulation problem, PAD, of course, that would be the right direction to take. But understanding that a lot of individuals, when we look after them, they have advanced stage of the condition with rest ischemia. So we do need to think about better way of assessing them, managing the pain, and to evaluate the pain. So I thank you for joining me for this webinar, and hopefully this is helpful to you in your practice in the future. Thank you.